Today it is my distinct pleasure to introduce Dr. Jason Allen Chesney, MD, Ph.D. As you know, he's our director of the Brown Cancer Center, and he's also serves as the Associate Vice President for Health Affairs at the University of Louisville. I didn't know this before reading this, but he received his bachelor's degree in anthropology, followed by his MD, Ph.D., all from the University of Minnesota. He then completed residency at Manhattan at Memorial Sloan Kettering Cancer Center, and then Cornell University Medical College in New York Hospital. He was a clinical fellow in the Division of Immunology at Weill Medical College in Cornell. And then we were able, probably Don Miller and others were able to lure him to Louisville. He was soon after named the James Graham Brown Foundation Endowed Chair. So he's the real deal with hundreds of peer-reviewed papers. The first time I heard him speak, I actually texted him. I don't know if he ever responded, but I said, "You will win the Nobel Prize." Do you remember that?
No.
Yeah, I think and he and I both agree that despite all that we know that he does for us, one of the most profound things and achievements in his career thus far is first-in-class novel of immunotherapy for melanoma, and that led to FDA approval, and which has led this to multiple trials for other solid organ cancers, and that is just such a phenomenal achievement. But when you ask him what he's most proud of in life, he's going to say his 4 children and his wife, Dr. Alden Clarer, who is now a breast radiation oncologist, has joined with our group. So please welcome Jason in teaching us, because he always does, today about resistance to immune checkpoint inhibitors. Jason?
Thank you, Chris. Can you hear me?
Mm-hmm.
Okay, great. Well, thank you very much. And for those of you who are on, it's kind of hard for me to tell who's on. I can see Chris, but thank you for joining me this morning to talk about what I think is probably one of the most important areas in oncology right now, which is cellular immunotherapy. I'm going to start off by just listing my objectives, just to make sure everyone understands them. And it's simply to understand the role of the immune system in controlling cancer. To understand the mechanism and clinical activity of immune checkpoint inhibitors. These drugs, as you'll hear soon, have really dramatically transformed and revolutionized oncology and the care of cancer patients, and then to learn about the clinical activity of tumor-infiltrating lymphocytes in cancer patients. Research support that really comes to the University of Louisville for some of the trials that I'll mention came from Bristol-Myers Squibb and Iovance. So, most of you know this already, but and I'm going to see if you can you see, I hope you can see my cursor, but right here in the middle of all these red counties is Kentucky, and Kentucky really is ground zero for cancer in the United States. And actually, yes, it's true, Don Miller lured me to Louisville, Kentucky along with John Eaton, but I wanted to do cancer research, and if you're a cancer researcher, you go where the cancer patients are. And that's turned out to be a really good decision. My dad taught me, if you're a cherry picker, go pick cherries where the cherries are, and this sort of worked out for me. You know, cancer, everyone talks about cancer as being this dreadful terminal disease, but it's really become chronic, and that's best reflected by some of the curves we've seen recently. This is data from the National Cancer Institute showing a fairly dramatic increase in the percentage of patients who have a percentage of the population that has cancer, from 3.6 million all the way up to 17 million. So the prevalence has gone up dramatically since 1975, when I was 6 years old. That's partly due to, certainly there was cigarette smoking causing lung cancer, but it's also due to the aging population from the baby boomers, and then of course the fact that patients are living longer. So there are more cancer survivors out there today than there have ever been. So, but most importantly, when the epidemiologists look at this curve, they are estimating right now that we will have a 50% increase in the cancer patient population in the next 2 decades. So that's a pretty big increase that we're predicting. The good news is that the cancer death rate has dropped dramatically. And on the left is the U.S. death rate. It's about a 30% drop. The peak was 215 deaths per 100,000. And now we're down to, at least in 2017, we were down to about 140. So, pretty significant drop. Kentucky, being number one for cancer, you can see peaked out not at 215, but got it up to almost 240, but has dropped nicely down to about 180 deaths per 100,000. So how do we make this drop that we saw, this 30% drop over 30 years, how would we make that happen in the next 5 years? And that's what I think about every day when I come to work and what my goal is. And certainly aggressive cancer screening programs are key for this. We're focused on the big three: colonoscopies, mammography, and low-dose CT screening for lung cancer. Most of these screening programs are underutilized. There's very little emphasis on them at cancer centers, and it's translating into cancers that could have been caught early, not being caught early, and individuals dying of the disease. And so there's been a big push to integrate our program across UofL Health and to make it easy for primary caregivers to get their patients in for colonoscopies. A recent statistic that made national news from one of our fellows was that only 7% of heavy smokers get low-dose chest CT screens annually. And these are the easiest thing you can possibly get. They take 5 minutes once you get in there. They cost, out-of-pocket cost without insurance is $180. With insurance, it's virtually nothing. So it's an important component of our screening program. Also, clinical trials of innovative immunotherapy combinations. I'll be talking about one of these, and Chris mentioned it briefly, but this is where we take where we are today and we try to move it to the next level by adding a second immunotherapy that is rationally combined with the existing approach that works. And then the third and the focus of my talk is the development of novel cellular immunotherapy approaches, and you'll hear about that in a moment. And so I'm just going to start off with a little Immunology 101. If you come to any grand rounds that I've spoken at, you've seen this slide before, but I like to get us down to earth right off the bat. And so the green cell here is a cytotoxic T cell, and it's got a T cell receptor. The ligand for the T cell receptor is class 1 MHC along with a specific peptide from a specific antigen. So since coronavirus is on everybody's mind, we can talk about SARS-CoV-2, and so SARS-CoV-2 has lots of foreign antigens. It infects nasal epithelial cells, bronchial epithelial cells. When it does that, there's lots of foreign antigens, foreign proteins that get cleaved, processed, and presented in association with class 1 MHC, and that becomes the ligand for T cells. And when the T cells get activated against these foreign antigen-presenting epithelial cells, which are they're your cells, they get irritated and they release bombs, basically. That's what these little circles are right here. The bombs are perforins and granzymes that eat holes in the membrane and cause the cell that's been infected with the virus to undergo apoptosis and die. The same thing happens with cancer. So, the average melanoma cell, I'm in a melanoma clinic right now, has 10,000 mutations. And those mutations, if they hit an exon, so they hit an open reading frame, will translate into a mutant protein, which in turn will translate into the cell not looking like self. So for a cancer to be successful, it has to figure out a way to evade the immune system in the body, and it's come up with a dramatic number of mechanisms to evade the immune system. The most dramatic, I would say, being that some melanoma cells will actually completely delete the entire class 1 MHC molecule, which is across thousands and thousands of base pairs of the genome. And once that happens, it's completely cloaked from the immune system. And on the right, this is just a scanning electron micrograph of a cancer cell being eaten by a T cell. Well, what happened roughly 30 years ago that translated into 2 Nobel Prizes a few years ago was the discovery that T cells that normally kill off virally infected cells and cancer cells, T cells have mechanisms that turn themselves off. And the reason they have these is to prevent excessive inflammation and autoimmunity. So we would all turn into big lymph nodes if T cells didn't have a way to turn them off. It's kind of like if you had a car that just had a gas pedal and no brake, right? It would just go, go, go. So the brakes are called CTLA-4 and PD-1. They're as a class called immune checkpoint inhibitors, like checkpoint Charlie. They're supposed to keep the immune system in check. And about 30 years ago, antibodies were being tested in mice that blocked these brakes, and it became apparent that when you did this, T cells became hyperactivated. So you basically put a 2x4 in front of your brake in your car, and you allowed your car to just go crazy. The same thing happened with T cells when you blocked their brakes with an antibody. And this is just a nice cartoon of the synapse between a tumor cell and a T cell and a tumor cell, and that synapse that I described earlier with the T cell receptor, class 1 MHC, and the fact that we have these signaling proteins that turn off the T cells, and if you can block them, the T cells become hyperactivated. So early on, I think it was 2012, we did a combination phase 2 first-in-human trial with ipilimumab and nivolumab. The first one blocks CTLA-4, which is one of the brakes. The other one blocks PD-1, which is the second brake. And to this day, this is known as the greatest, the highest overall response rate for an immunotherapy, and it became the first and only, as of today, combination immunotherapy that was FDA approved. It's since been shown to have efficacy in other types of cancer like renal cell and more recently small cell. But you can see this is called a waterfall plot, and each one of these columns is an individual patient and their tumor volume. We use a surrogate. We use the maximum diameter of the tumor, so it really understates the changes in their volume. But you can see that there was a marked reduction in the vast majority of patients who got the combination. And a lot of these patients are still alive today. Some of them are still receiving therapy. And this is just a nice example of a patient that I like to show. This patient had a large chest wall mass. You can see it right here. And when they were treated with the combination of these two antibodies, it looks like a surgeon removed the mass, basically, right? It's just completely gone. And my little photograph here of the mass itself and what it looked like. And this patient did not undergo surgery. This patient simply received immunotherapy, received this combination therapy of two immune checkpoint inhibitors. And what's important to note is that, so this all started for us in 2012, and melanoma, we got the approval in 14 to 15. But since then, we have seen this explosion in FDA approvals for multiple cancer types. And that's because, this is not a targeted therapy in the sense that it's not targeting a specific mutation. What it's targeting is the difference between a cancer cell and a normal cell. And so by activating these immune cells, the cytotoxic T cells, it doesn't matter if you're a melanoma or a cervical cancer to the immune system. If it looks different, it's going to kill you. And so what really matters is how many mutations you have. And not surprisingly, melanoma has the highest number of mutations, but number 2 to melanoma is non-small cell lung cancer. So to me, it's virtually the same disease, and we use the same drugs. We've got FDA approval for the same two drugs I just talked about, ipilimumab and nivolumab. We use another anti-PD-1, pembrolizumab, for lung cancer. And we're really seeing dramatic reductions in the death rate from lung cancer right now. That story will be told in years from now when people look back at the numbers. But I can tell you that we used to have a lung cancer patient die each week, and I haven't had one die since January. So things have changed dramatically. But then you can go on from there and just see, it's not every cancer type yet, but probably in the next 5 to 10 years it will be. More recent approvals, triple negative breast cancer, which is just horrible, and you don't have any anti-estrogen options. That's an important milestone. And then this right here, TMB high solid tumors, that stands for tumor mutation burden. This is the first. I'm gonna have to close some doors here. Hold on one second. That's all right. That's all right. They were moving some chairs around, I guess, out there. So the TMB high solid tumors, this is the first tumor agnostic approval that we've gotten for an immune checkpoint inhibitor. It's pretty incredible. So pembrolizumab, which is an anti-PD-1 up here, it is now approved for any cancer type. Doesn't matter what kind of cancer it is, as long as you have 10 mutations per megabase. So any cancer type. So it's truly a tumor agnostic approval for these immune checkpoint inhibitors. So Chris sent an email yesterday, not to me, but to all of the chiefs, and said that don't forget you're always supposed to include a patient case, which I'm going to include right now. So this is patient DR. He's not a physician. He's 43 years old, and his right third toenail fell off, and then a pea-sized pimple appeared in the nail bed, and then started to bleed over the course of several months. He went to a dermatologist, and the dermatologist biopsied it and confirmed a 5 millimeter deep ulcerated melanoma. The patient was referred to Dr. Kelly McMasters and Jared Little, and they did a amputation of the right third toe, as well as sentinel lymph node biopsies of both the popliteal and inguinal basins, and a single node was positive. A single node was positive, and he was sent to me for consideration of adjuvant immunotherapy. We gave him adjuvant pembrolizumab, so an anti-PD-1, for 7 cycles, but then he developed multiple new pulmonary nodules, and we biopsied one of them, and it turned out to be BRAF wild type. BRAF is a common mutation. It's an actionable mutation, so there are drugs that are specific for it that work. He had a TMB, or tumor mutation burden, of 7 mutations per megabase, and then his PD-L1, which is the ligand for the break or immune checkpoint protein PD-1, the expression level was 3%. And so, when these patients present, we have a big discussion about treatment options. This patient, because he's BRAF wild type, he can't get BRAF inhibitors, but he certainly has a favorable immunophenotype. However, he just progressed while on adjuvant pembrolizumab, meaning he's got a pretty immunoresistant cancer. And so our options really are to try to escalate the combination immunotherapy or try cellular immunotherapy. And the escalation would be using a combination of ipilimumab and nivolumab, which isn't nearly as effective in patients who are already intrinsically resistant to anti-PD-1 therapy. And we can also do combination therapies with oncolytic viruses that have been genetically engineered to stimulate the immune system. One that's already FDA approved that we did the early phase trials on, and then the combination trials on, is Telimagene laparepvec. It's an oncolytic herpes simplex virus 1 that's been genetically engineered to express the dendritic cell cytokine GM-CSF. And then, of course, trials. We have new oncolytic viruses. CMP100 is a TLR9 agonist that stimulates the immune system, and multiple others. But in this guy's case, because of his age and the aggressiveness of his cancer, he had a digit melanoma, which is always worse than a non-digit melanoma. It had been there for quite a long time before it was resected. It was deep ulcerated. He had positive sentinel lymph nodes. So he had a very high risk of recurrence, but for him to recur with multiple pulmonary nodules while on adjuvant pembrolizumab meant that this was an aggressive melanoma, and we chose to recommend cellular immunotherapy. So he went on a new type of therapy called tumor infiltrating lymphocytes. A second one is called CAR T cells. That's where you genetically engineer T cells to go after melanoma, and we didn't have that available, and so that wasn't an option for him, but that is one that we're working on. And so what are tumor infiltrating lymphocytes? So essentially what they are is we get a surgeon to resect a tumor, and then we isolate the T cells from the tumor and expand them, activate them, and put them back into the patient. And this is a pretty complex procedure that I'll go into a little bit of detail in a few minutes, but at the time we opened it in 2016, there were no sites in the country that were not on a coast. They were in New York, California, and Texas, and Florida. That's where they were. And so when I had a patient who needed to go on this in 2015, I had to put them on an airplane to get this. And so we opened it here in 2016, largely because we had a bone marrow transplant floor we could do it on. We had a 10-year plus experience with high-dose interleukin-2, which is required for it. And we have an incredible surgical oncology program. I mean, really one of the top ones in the country, in my opinion. Today, this procedure is likely to be FDA approved for melanoma sometime in the next fiscal year, and we think cervical cancer will be also in the following fiscal year. And we'll be one of the only sites in the country, but actually in the world, that'll offer this, because we're going to be one of 10 that'll be certified to provide it. And so I gave this talk on April 10th at the American Association for Cancer Research annual meeting. It was a plenary session there on immuno-oncology and cellular therapies. And so I just grabbed some slides from it because I thought it would be interesting for this crowd. I want to mention that all this data would not have happened without Wendy Knight. She's my research nurse who's been running and leading the TILS program at the University of Louisville. She's had a great partner in the last, I think, 6 months or so. Sierra Harevik, and then Stacy Baum was involved in the cervical cancer TILS program. So there's currently no approved agents for metastatic melanoma patients who progress after immune checkpoint inhibitors and BRAF inhibitors. Nothing's been proven to work in that situation. We see response rates, but nothing's been done in a randomized fashion, and survival is certainly unknown. And some of the percentages are pretty bad. So with retreatment with immune checkpoint inhibitors, if you progress like DR did, 4 to 10% overall objective response rate, and median overall survival of 7 to 8 months. TILS, the cell-based therapy, has demonstrated efficacy in single-center trials, and so we opened up a phase 2 multi-center trial to go for FDA approval in patients with metastatic melanoma who had progressed after ICIs or immune checkpoint inhibitors. And so these were the eligibility criteria. Our endpoints were measuring overall response rate, but then eligibility criteria, we need 2 tumors. Can't do it with 1 because you cut one of them out and you need 1 to measure. And the patient had to be in good shape, basically. Our demographics were pretty straightforward, but I want to highlight a couple things. And one is that 100% of the patients enrolled in this study, 100%, had been given an anti-PD-1 or anti-PD-L1, the ligand for anti-PD-1. So had progressed after an immune checkpoint inhibitor. 80% had progressed after anti-CTLA-4, which is ipilimumab. So really the vast majority had no immunotherapy options for them. And then over here is the target lesion sum of diameter. So that's basically, we measured the maximum diameter of each of the target lesions, not all the tumor burden. But it was very high, 10.6 centimeters, because you're only allowed to measure up to 5 lesions, depending on if they're all in one organ, you can only do 2. But in this case, the average was 10.6. So these are high disease burden patients, refractory to immunotherapy. Virtually anybody who had a BRAF mutation had to have had a BRAF inhibitor already. So really no options, but go home and get your affairs in order. The median prior therapy was 3.3 prior therapies. So I'm going to go into a little bit of detail about what the procedure is, because I think it's important to understand it's not simple. So we bring the patient in, and the first step is you got to make sure they have a couple tumors. The second step is you have to find a surgeon who's willing to take out a tumor or a piece of a tumor, and then you ship the tumor off to get the T cells isolated, expanded, and activated at a central processing facility. And while that's all happening, and sometimes the cells don't grow out, but while that's happening, you then put the patient in the bone marrow transplant unit and give them cyclophosphamide followed by fludarabine, which drops their total white count, but in particular, it nails their lymphocytes. It's transient. This is not a myeloablative regimen, so their numbers come back. But at the time of when we get the product back, which is the TILs, and the commercial name for this is lifileucel, their white counts generally are 0, and we give them the TILs over a few hours, and that's day 0. And then days 1 and 2, we give up to 6 doses of high-dose interleukin-2. And when you give high-dose interleukin-2, you drop their pressure. You have to frequently have to maintain their pressure with pressors. You're giving them renal dose dopamine to keep their kidneys perfused, and they can go into respiratory failure and all sorts of other bad things. It's probably the most dangerous part of the procedure. And then after about a week of recovery, we send them out. So the whole thing takes about 3 weeks from the time they enter the hospital to when they depart. And it's not fun. Most of the side effects come from the chemo and from the high-dose interleukin-2. The cell infusion is autologous, and unless they have a reaction to the preservative, which is dimethyl sulfoxide, I haven't had any reactions, to tell the truth, with any of the patients. But what we see is typical stuff with high-dose interleukin-2, like chills, fatigue, low blood pressure, tachycardia, and then also with the lymphodepletion, obviously we get thrombocytopenia, anemia, neutropenia, et cetera. But importantly, all those adverse events happen when we're giving the therapy. They're gone by 2 weeks from when they get their infusion, and then after that, very few side effects happen. And so for all of that, what do we buy ourselves in patients whose other doctors have told them to go home and get their affairs in order? Well, we get an objective response rate of 36.4%. So that means that the index lesions had a greater than 30% reduction in their maximum diameters. A partial response rate it makes up most of that. Another 43% had stable disease, and very few had progressive disease, 13.6%. Importantly, when we looked at characteristics that would suggest who would respond and who wouldn't, we found nothing. I mean, we looked at everything we could think of and didn't find anything. And so this is the waterfall plot, and it's easy to sit back and look at this and go, oh, this looks great, but 20 years ago we didn't see what the waterfall plots of 20 years ago were completely flipped, where we would see a few responses and the majority would progress. And so this looks a lot like the ipilimumab nivolumab waterfall plot I showed you before, but these are patients now who have progressed after immunotherapy, and you can see that the vast majority had their tumor burden go down, 81%. And then what's important about this is all the asterisks that you see on each one of these, those are patients whose response actually didn't just maintain over a 8-month period, but got better. So they flipped from being stable disease. Some flipped from being stable disease to being a partial response, but their tumor burden actually continued to get better with time, suggesting durability in those who respond. And that's shown nicely in this swimmer's plot. It used to be called a swim lane plot by the statisticians. It became swimmer's plot. You can see why. It looks like an Olympic pool. But these are all partial responders and a few complete responders, and the durability is indicated by the time. And as of December, when we did this data analysis, we hadn't reached the median duration of response. And in fact, one of the patients, number 34 here, who had been a PR, became a CR at about 24 months after their TIL infusion. So again, demonstration that long-lasting, durable immunity is happening in a certain percentage of these patients. And that's shown here. We just published this. It's actually online this week. It's not even in print yet. But one of the reviewers wanted overall survival data, which you don't normally show this early on, but we did it. And we did actually, by the time we did the rebuttal, we had reached the median, and it was 17.4 months. And you go, well, that's not too good. Well, when you think about it, these are patients who have basically, a matter of a few months to live. And the fact that even half half that died in those 17 months lived a little bit longer probably was worth it. But the other half, on the other hand, it's looking like, at least today, that we're reaching a shoulder in the Kaplan-Meier survival curve. And we believe today that most of them will live normal lifespans. But only time will tell, and I'll be back probably in a couple of years giving grand rounds showing the follow-up data on this. And so here's my summary. In heavily pretreated metastatic melanoma patients who progressed on multiple prior therapies, we obtained a 36% overall response rate. Our median duration of response was not reached. We saw responses deepening over time. We had a patient who converted from a PR to a CR, and we believe that TILs have significant clinical efficacy and durability. The FDA is evaluating the product right now, and we do believe that in the next year we'll see FDA approval for melanoma, and the cervical cancer data look just as good, to tell the truth. So I'm going to go back to my patient DR. And so patient DR, remember I said he had a high-risk melanoma, and after 7 months of anti-PD-1 or pembrolizumab, he recurred in the lung. And I wanted to show, I apologize if it's hard for you to see this on your screens, but I circled some of the lesions of interest. So this is week -2 to getting TILs, week -2. And here's a right upper lobe mass, a couple down here in the, I think that's right middle, and then here in the left lower, a few more. And these are just representative. He had about 20 or 30, I think, if you counted all the little ones. But you'll see why I mentioned I show these 3 cuts. So he gets his TILs and has a pretty dramatic response of that right upper lobe mass. It's just completely gone almost immediately. You can see it right there. But then by week 36 and week 48 and week 72, it's just completely gone. Unfortunately, by week 36, you'll see that this little guy here, he's still there, but then come week 36, he's starting to grow out. And then these in the left lower lobe that shrunk dramatically start to grow out as well. And so what I did for this patient, DR, was I put him on pembrolizumab. And so you might ask, well, why would I do that? I mean, this is a guy whose melanoma is resistant to pembrolizumab. It grew right through it. He developed all these lung lesions while he was on pembrolizumab. And the reason that I did that was that the TILs themselves, when they're isolated from the tumor, express PD-1. That's why the patient's tumors are growing, because the T cells are turned off. They're expressing PD-1. Well, we've now expanded them, activated them, had a response, but these cells are expressing PD-1. So I kind of added an anti-PD-1 to try to activate the TILs themselves. And sure enough, when we did that, you can see that the patient, this mass here that showed up fairly dramatically, completely went away. And these that had gone away and came back went completely away in the left lower lobe. And that's the title of my talk. It's a big question mark for me, but one of the biggest challenges in oncology today is trying to overcome intrinsic and acquired resistance to anti-PD-1 therapies, to immune checkpoint inhibitors. And this patient and a few others show very nicely that TILs can overcome resistance, intrinsic resistance, which is what he had to immune checkpoint inhibitors. So I think that makes TILs an important component of our weaponry against cancer today. And so I'm almost done. I want to just show you some nice pictures of patients of mine who've been treated on this trial. This came out in the University of Louisville magazine, this quarter's magazine, and this is Valerie Snap. It's a picture of her Rottweiler on her farm down in Nashville, Tennessee. And Val had gone to Vanderbilt and been told there was nothing they could do. And then she went to MD Anderson, and they said, "I'm sorry, you're 73 years old. There's nothing you can do." And then she called us, and I asked her to come up and see me, and she came and talked to me. And I said, "Well, let's try TILs." And at the time, we hadn't treated anyone with TILs over the age of 70, so she was my first. And she had a big mass in the middle of her chest that was completely unresectable and growing, and it's completely gone now. I think we're 2 years out now from that, and now she's alive. And she says, I look out over the farm and it is so beautiful. I think how blessed I am to be able to be here to see this. How many people have been told they wouldn't be here for long and have not had the chance I have had? And so she is living her life and enjoying herself because she went on this therapy. This is Jennifer Phillips. I'm allowed to use names because they were on TV. And so Jennifer is a cervical cancer patient, went on our cervical TILs, and very similar story, and also lives in Tennessee. She's from Knoxville and is doing wonderfully today. And then this just came out last fall. This was Tony Burton. Tony was our first lung cancer patient. We treated him last summer, and he had a dramatic response, and he's doing great. No evidence of disease, living his life out there talking to television stations. This article went out to 32 markets in the United States, and we've had just a bunch of phone calls from people wanting to come here to get TILs. So our cellular therapies for cancer are transforming oncology. You've heard all about TILs. That lung cancer patient was our first. We have a trial now open for, I think, 105 patients. We're doing new trials where we precondition the patient with immune checkpoint inhibitors. So we try to activate their TILs up front and then take the TILs out. The clinical data with cervical is very compelling, and we're expecting FDA approval for melanoma sometime in the next fiscal year. We're not stopping there. CAR T cells is a huge effort right now. We've invested millions of dollars in one of the only CAR T cell dedicated GMP labs in the country, certainly in the central United States. We've already initiated an anti-CD4 CAR T cell. It's the first in human that targets CD4, which is a common, it's a T cell antigen, but it's expressed on a lot of very lethal leukemias, and it's never been tried because of the concerns with AIDS. We're expanding to 5 trials, one of which will be melanoma, and one will be pediatric neuroblastoma. We've formed a new program called the Blood Cancers, Cellular Therapeutics, and Transplantation Program that folds all of this work in with the bone marrow transplant program and our blood cancers program that allows us to really create a focus around this effort that we believe will help reduce the cancer death rate by 30% over the next 5 years. And a lot of that support's come from Tom Dunbar and his family, so I thank them. And so this is my last slide, and I just want to mention the guys on the top row there are all the surgeons, and you don't get to work with people like this at many places, I have to tell you. I think Chris told you I spent time in New York and in Minnesota, and Minnesota has an outstanding surgery program, just absolutely outstanding, nationally recognized. Every resident gets a Ph.D. there. It's a big program. They service the whole state and the whole region. Our guys are better. I'm telling you, Mike Egger, Victor Van Berkel, Kelly McMasters. I mean, these guys are incredible. Jared Little. They are the ones who are working with me to identify the tumors, to get the lesions out, to do it safely. We've not had any problems with the harvest. It's really the easiest step of the procedure, and every one of them has my gratitude forever because they've helped me save these people's lives. Don Miller is the one who brought high-dose interleukin-2 to Louisville, Kentucky, to Kentucky, I should say. Without high-dose interleukin-2, we wouldn't be able to do TILs. And that was part of the reason. We had a great surgery group, and we had high-dose interleukin-2, and we had a transplant floor. And then last, Tom Miller on the left. Many of you probably don't know him personally, but he's the CEO of UofL Health. You may have noticed that there have been a lot of changes since he got here. I think it was about a year and a half ago now. And he has been incredibly supportive of the Cancer Center, of the Oncology service line, is helping us grow the trials program as we grow the cancer care program. And then Tony Gansel, our dean, who really is providing key support for the cancer trials program through her IGT allocation, which has been absolutely essential for this program. And I'm going to stop there and take some questions. I'm all ears. I don't know how you do this from here.
All right, thank you so much, Dr. Chesney. Outstanding. If anybody has a question, you can unmute your microphone and ask, or if you would like to type it in the chat area, we can read it for him. And we do have a question in the chat area, Dr. Chesney. It says, can we see future use of TILs for bladder cancer at UofL?
Yeah, I mean, bladder has a high mutation rate. The most common bladder cancers are caused by carcinogens from cigarette smoke, but a lot of non-smokers get bladder cancer. And it is responsive to anti-PD-1s. It's not as great as melanoma. And so the plan is, as we get our first FDA approval, just like with the PD-1, PD-L1 inhibitors, we believe there'll be an explosion of TILs. The biggest difference is that you can't just, you don't just stick the patient with an IV and give them a 30-minute infusion, obviously. So this can only be done at tertiary care centers like ours. But I believe that bladder is on the horizon.
So Jason, your second slide, I believe, really caught my attention because the scatter plot mat of cancers follow the Ohio River down into the Mississippi River, down into the Delta. Matt Cave, I think, is really our our toxicology, I mean, look at that. I mean, that looks like water, water, water. And so from a
Yeah,
prevention standpoint, toxicology standpoint,
sure.
you know, hmm, you're curing cancer, and we need to find the root cause of what dysregulates our innate immune system to begin with.
Yeah.
I just find that to be a fascinating slide.
Yeah, so I have a more detailed slide, but so one thing for sure is that you can take this heat map of the country and do it for smoking rates, and it'll look almost the same. So smoking drives cancer deaths significantly. About 600 plus thousand die of lung cancer a year. I'm sorry, 200,000 die of lung cancer a year, but out of a total for all cancer types of 600,000. So it's 1/3 of all the cancer deaths is from lung cancer. So smoking is a major, component of this, and that's why you see a lot of that concentration there. And smoking obviously also causes bladder cancer and other head and neck cancer and other types of cancer too. So it really does drive cancer death rate up. The other thing is that I call this kind of the valley of death here, this whole thing right here. I don't know if you can see my cursor, and part of the reason is that relative to our population density, we have a very low percentage of academic cancer centers in our area. I mean, to have, it's just a reality relative to the coasts, and so that's also, it's about access to healthcare. I mean, I have patients who live in Pikeville, and I hear the stories of how they were mismanaged because they don't have enough doctors, or there's not, they're seeing mostly, NP straight out of school who don't have experience or whatever. And so that's driving a lot of it. But then, yeah, you're right, there is a water basin that follows all this. So I never thought about it.
Hey, Dr. Chesney, I have another question from the chat area from Dr. Krishnasamy. She says, great overview. Can you comment on the CPI endocrinopathies and the aspect of irreversibility, and also does adding TILs alter the endocrinopathies?
Yeah, so no, I haven't seen the TILs alter any of the effects of immune checkpoint inhibitors on the pituitary gland, the thyroid, the pancreas. The comment about I guess it was the durability of the effects. So what the question relates to is, so I didn't go into any details about the side effects of immune checkpoint inhibitors. So anti-PD-1 therapies, which are now the mainstay of immunotherapy, have very, very low rates of autoimmunity, which is under 5% in most trials. They can activate T cells against basically any organ in your body. The most common ones are the lung, the liver, the colon, but also they can activate CD8 positive T cells against the pituitary gland, the thyroid gland, the pancreas. And when that happens, unfortunately, it does become permanent. So thyroid, big deal, you take some Synthroid. The pituitary gland, big deal, you take 5 milligrams of prednisone for the rest of your life. Pancreas, big deal, you're taking insulin for the rest of your life. And at least my clinical experience and my review of literature when cases come up, difficult cases come up, is that these are permanent changes. The thought processes, and the one that I've studied the most is the beta cells in the pancreas. Once you become the diabetes becomes clinically apparent, those beta cells are toast. I mean, you've got infiltration of CD8 positive T cells in there, and there's nothing you're going to do with steroids or other immunosuppressives to protect that pancreas. That doesn't mean I haven't tried. I have, and I've not succeeded. I've had this happen to 3 patients. That tells you how rare the autoimmune pancreatitis is, but because I probably treat 60 a week with an anti-PD-1 right now. And so I've had 3, the 3 who developed type 1 diabetes, it all happened in 1 month. It was probably from a concurrent viral infection that infected the beta cells that activated the immune cells against their beta cells, although I'm not sure what happened, but it all happened in 1 month. So I've not seen reversal of any autoimmunities against the endocrine glands ever, to tell the truth.
All right, another question from the chat area from Dr. Sam Reynolds. Can you comment on the use of, I guess, CAR-NK in solid tumors? Curious about its application in melanoma specifically.
Yeah, so the nice thing about NK cells is they're longer lasting, and we don't know if they're going to be able to overcome the issues with CAR T cells and solid tumors. But there have been some early studies that have suggested it. I really have to say I'm no expert with NK cells as a vehicle for CAR T cells, but it's one of the areas that our scientific partner at Stony Brook is looking into, but I'm not sure. Right now, our plan is to really use more traditional CAR T cells in melanoma. And I have to admit to everyone here, I'm sure you all appreciate the shorter talk, but it's because I'm over at our beautiful Brown Cancer Center Northeast with 38 patients out there waiting for me to start clinic. So I have to check out a little bit early if that's okay. But I'm happy to take questions through the email if there are any more.
So as I said at the beginning, Jason's the real deal. He's a scientist, a researcher, educator, and he's a clinician, and he has 38 patients waiting for him. So we're going to say thank you very much, and let him go. And anybody can email him if they have additional questions. Thanks for that wonderful talk. And everybody can drop off. Jason Puckett wants to remind us that next week is, oops.
Oh, I'm here. No, yes, next week is Awards Day. I don't know if Dr. Cook is still on, if she wanted to say anything about that real quick, but it's the same time. It'll be 8 a.m. Next Thursday, May 27th. I know Dr. Cook and the residency program fellowship coordinators have all been working very hard to put this together, and it'll be virtual, but it'll be great. I know last year with the things going on, we did something online, but this year we are going to have a program, and we hope everybody can join us. It's going to be great. It's always a great day for everybody.
Thank you, Jason. Thank you so much, and everybody have a great week. See you next week.
Thank you, Dr. Kruger. And again, thank you again to Dr. Chesney for another outstanding presentation. And I want to thank everybody. If you're still here, thank you for, it's been a unique Grand Rounds season, and you guys have been, it's actually worked out very well given the circumstances, and we've seen great attendance. We've seen some great interaction, and just want to thank everybody for hanging in with us, and thank you again. And it's been really good. We'll see you again next week for Awards Day, and then we'll see you in September as we resume Grand Rounds. So thank you, everybody. Thank you, Dr. Kruger, for accommodating and for being flexible, and for helping make it happen. So
welcome. Bye-bye.
See you guys. See everybody. And Tim, remember to download the thing.